Hey everybody, we're going to go over seizure disorders this time. So remember in one of our other lectures we talked about this AEIOU tips. Remember how it stood for alcohol, acidosis, ammonia, arrhythmias, endocrine. As we're going down these letters, when we talked about it last time, it was dealing with our psychiatric patients. Well, this time when we're doing our assessment, we are going to go into the S, which is our seizure disorders. So seizures. There are so many different types of seizures that we could deal with. There are a lot of different information we need to know about it, such as seizures are not really well understood. They still aren't. Here in 2021, we still don't fully understand a seizure. There's still the belief that some may be due to structural lesions in the brain. These lesions, they believe, can cause permeability issues between their sodium and potassium ions, which then are causing the neurons to fire erratically and allows that impulse to occur. Some other things that may cause and have an effect on a person having a seizure could include things like stroke, head trauma, toxins, which include both alcohol and drug withdrawals. That's probably one of the ones we might see frequently. Hypoxia, hypoperfusion, hypoglycemia, infection, metabolic abnormalities, brain tumors or abscesses, vascular disorders, eclampsia, and drug overdoses. Remember, we talked about eclampsia during the pregnancy chapter as well. When it comes to our seizures, we're kind of broken down into three categories, or at least how they're onset. You can have a focal onset, a generalized onset, or unknown, well, that's probably our life, is unknown onsets. Then in 2017, these onsets got a kind of a new facelift to them. So they're further broken down to determine, based off the focal, generalized, if the person is aware, and then further on, they get broken down into motor. So we'll start off, we'll talk about, our first thing we're going to talk about is we're going to talk about a generalized seizure. So when we talk about a generalized seizure, it's normally going to think about like maybe possibly a grand mal. That's your common thought process about it. This is previously known as a grand mal. The seizure involves both sides of the brain and results in a loss of consciousness. This always will have a loss of consciousness in one way or another. They also have varying lengths of time and are, again, divided into motor and non-motor seizures. So here's what it kind of looks like to the brain when you look at an EEG of the brain when you have a grand mal seizure. It just goes chaotic. The first one we're going to talk about, the first seizure style we're going to talk about, it's going to be the one that's most often missed, an absence seizure. So in an absence seizure, it was previously known as a petit mal seizure. What this seizure does is it's a brief lapse of consciousness without loss of posture. As you can see with the kid, this is one of those things where it's normally happening in the elementary grade students, and they're sitting there and they just kind of drift off and daydream, and they're gone. They don't lose posture, they don't fall, they don't collapse, they don't shake. They just zone out. And that's what makes it so much of a risk for people. And then also the timeline, it's not a very long seizure that they're going to have. It lasts for approximately 15 seconds. And this can happen in adults, but normally if a child has it, they're normally kind of waking up through it and getting out of it by the time they hit their 20s. Now, there are more types of seizures too that are considered generalized. You have your atonic seizure, which is also known as your drop attacks. I would love to put a video of this up, but I didn't figure it'd look pretty good because of the fact that they literally have an abrupt loss of muscle tone, loss of posture, and just suddenly just collapse on the ground. Now, these individuals are going to have a high risk for having complications associated with falls and trauma for the falls. So if you're dealing with this patient, have that high suspicion. Now I got to think about cervical spine protection. I have to worry about spinal protection. I have to worry about head trauma, brain bleeds, facial fractures, etc. Maybe in broken extremities. And then you'll have your myoclonic seizure. This is a brief muscle contraction in a single event or in a series and they occur on both sides at the same time. So it's basically just one giant contraction and let go. One giant contraction and let go. And that would be your myoclonic seizures. And finally, the grand mal, the tonic-clonic, the one when you hear somebody say, I think this person had a seizure, the one that everybody immediately jumps to and thinks that this is the kind of seizure they're talking about. Your tonic-clonic. So this is where the patient will start off, having this aura feel, the lightheaded, the dizzy, the hallucinations. They go into the tonic phase where they have massive tensioning up. They start having the jerky motions. They lose their consciousness because these are all been unaware generalized seizures, remember. And then you get the clonic phase, which is your convulsions, your violent shaking, your uncontrollable twitching, and occasionally you get difficulty breathing and lack of breathing. And then finally you go into your postictal sleep. So this is the stage after all that's gone through. The body is so depleted of sugar, so depleted of oxygen, the patient's just exhausted, and they fall asleep. They have confusion if they wake up, amnesia, and nauseous once they regain consciousness. I had an individual who, we had a 911 call for an individual who had a tonic-clonic seizure, was in the postictal phase when I had the opportunity to meet the patient, would not respond, the whole 9 yards. We ended up loading him in the cot. Because I was afraid of running into that issue, the confusion in that, this is back when we could actually have family members ride in the back of the ambulance with us. I had the husband ride with us so that when the person woke up, the first thing she saw ended up being her husband instead of seeing a stranger. It actually helped in the patient care scenario because he was able to talk to her because he was a face she recognized, even coming out of confusion, and kept things calmer. I'm guessing you've also been in scenarios where you don't have that opportunity and you have a patient who wakes up and they are in a massive panic, grabbing, fighting, petrified of being in the back of the ambulance until they realize that they had a seizure and you're there to help them. So now let's move into the partial seizures. These partial seizures include things such as what you're about to see here.
It's really hard to explain what happens in my seizures, because it's like being in a dream or something. First of all, I get butterflies in my tummy. And then I get this weird feeling, it's like nothing else I know. I can hear people talking around me, but it's like they're slowed down, or they're talking in a different language, because I can't understand them at all. I kind of know there's stuff going on around me, but the world doesn't make any sense anymore. Apparently, sometimes I say funny things that don't make any sense, and if someone tries to ask me a question, then I don't reply. It only lasts about a few minutes, but I feel like it goes on forever. Afterwards, I'm okay, but I usually have a headache and need to go for a rest for a bit. My friends know that it is because of my epilepsy. They help me go and find somewhere quiet or take me back to my dad's.
If someone has epilepsy, this means...
So that was talking about that focal seizure. So here's, focal seizure is also known as a simple partial seizure. When we're looking at it, you can see that in this image. It's kind of pixelated, and I apologize for that. But it's a very specific side. It's also only going to occur on one side of the brain as well. It's only going to be one hemisphere, I should say. So when we're dealing with it, the tingling sensation or movement, grimace, if you remember the parts of the brain as you go through, you'll see it. And you'll see that here when you're looking at your focal seizure, you'll see that it's only in certain parts of the brain that you'll see this issue occur. And when it does this, it starts in one area and then it will kind of spread. With a focal seizure, it can be either both, or these partial seizures. It can be a patient who has awareness of what's going on. Some of these partial seizures, like the one we just talked about, she's completely aware of everything that's going on around her. And that's in comparison to this next partial seizure that we're going to look at. So now that little girl had no clue about anything going on around her. So she had a motor onset type of part of her seizure, which is producing changes in her muscle activity. There you go. Her muscle activity. Apologize for that. Her produces changes in her muscle activity. She's getting the weakness, the twitching, the stiffening of body parts. She's having that repetitive motion. Whereas when we look at our little girl from before that in this video over here, this is a non-motor onset seizure. So this affects your senses, results in changes in smell, taste, hearing. That's what she's describing in that situation. And when people get some of these different types of seizures, as I was saying, it starts in a section of the brain like the motor or sensory cortex, and then it spreads orderly. It spreads in an orderly fashion around the brain, which is a system called the Jacksonian march. And finally, all these seizures kind of tie together. And if you have a person who has a continuous seizure lasting more than 30 minutes, 2 or more seizures without regaining consciousness, or a prolonged seizure that lasts 5 and 30 minutes, these people should be treated as a status epilepticus. So when we have any of these patients, some complications we could run into. We could run into aspiration, bone and spine fractures, brain damage due to hypoxia, brain damage due to depletion of glucose, and dehydration. And we can help and treat most of these issues. So if you have an unresponsive patient, we're going to check a blood glucose. If they're low SpO2, low end-tidal, or high end-tidal, depending on what the problem is, we will give them oxygen. We'll treat them appropriately. We will be worried about those spine fractures to make sure that they don't have an injury. And aspiration, if we need to and they're unresponsive, we take over their airway. So our assessment. When we're checking out on a patient's assessment, you're going to want to check out for history or frequency of any history of seizures. Are they compliant with taking their medications, or have there any medication changed? This is all rudimentary stuff that I'm telling you. Description of the seizure activity. That's a big one that you can ask bystanders. What was the duration? Was it atypical, or was it typical of how this person normally has a seizure? Did the patient have a presence of an aura? And you can sometimes ask your patient on those longer transports when they come out of that postictal. Say, did you sense it coming on? Did you see an aura? Generalized or focal seizures. So you got to kind of see which one you're looking at. Was it the grand mal absence? Was it something that was just a twitching and a tightening of the area? Incontinence, tongue biting, time to return to baseline. I remember very early in my career, one of the things, and I'm guessing each of you have heard this or done this, to determine the difference between a patient who is having a real seizure and a real unresponsive emergency to those who are faking seizures. How many of you probably have done, or faking unresponsiveness, have probably checked incontinence, looked in the mouth for the tongue biting, looked for the blood to verify that this is actually truly a seizure or if this person is actually faking the situation? Other things you can look for in your assessment are recent or past history of head trauma, recent history of fever, headache, or a nuchal rigidity, which means neck stiffness with flexion, and past significant medical history, such as diabetes mellitus, heart disease, and stroke. The treatment for your seizures, any of them, partial, general, whatever, it's going to be start off protecting them from injury. Move the islands away from them so that they're thrashing. They're not going to smack themselves and hurt themselves more. Our job, make sure we have an airway. Make sure we can ventilate them. When that patient comes around, make sure you're giving them good emotional support. Get an IV or an IO. And then also, if you need, give them some benzodiazepines as well. And finally, long-term care. I don't know if any of you have seen this. It really threw me personally when I first saw this. Is a vagal nerve stimulator on a seizure patient. I had an individual who had a seizure in a store. We walked up. Family was like, "Yep, we activated. We didn't have the patient's magnet, or we did have the patient's magnet, and we activated their vagal nerve stimulator, which is meant to backfeed into the vagal nerve or vagus nerve, and cause to stop the seizure by feeding an electrical pulse back up the system." If you put a cardiac monitor on, you're gonna have pacer spikes, just like you would on a patient with a pacer, except for the rhythm won't look quite the same, but you will see pacer spikes included in your rhythm strip. They turn these on with a magnet. Family will do this if the patients are saying, maybe their aura starting or they start having a seizure. They'll put the magnet on there because it's going to try to reduce it and reduce the postictal phase for them. Like I said, it will look weird on your cardiac monitor. That was the biggest thing, and you'll see this little bump on their chest as well from where they have an implanted device. With that, I know the seizure conversation was really quick, short, and hopefully painless. Please finish your little quiz that's associated with this, and hope you enjoy this quick refresher on seizure.